Rectum and anal canal. Introduction. The lowest part of the gastrointestinal tract is formed by the rectum and anal canal. Useful components of the food are absorbed and waste material is expelled from the anus, which is the external opening of the anal canal seen in the perineum. Anal canal is heavily guarded by the sphincters and is subjected to many maladies. Balanced food at proper timing decreases these maladies. Rectum dissection. Identify the relation of the peritoneum to the upper two-thirds of the rectum. See the structures/viscera related to the rectum both in male and female cadavers. Cut through the rectum and examine its mucous membrane with a hand lens. Find the superior rectal artery, as the continuation of the inferior mesenteric artery. Trace it onto the posterior surface of the upper part of rectum and follow its branches downwards on the posterolateral surfaces till the lowest part of the rectum. Trace the middle rectal artery from its origin from the internal iliac artery till the wall of the rectum. Features. The rectum is the distal part of the large gut. It is placed between the sigmoid colon above and the anal canal below. Distension of the rectum causes the desire to defecate. The rectum in man is not straight as the name implies. In fact, it is curved in an antero-posterior direction and also from side to side. The three cardinal features of the large intestine, e.g. saculations, appendices epiploicae and tenyae, are absent in the rectum situation. The rectum is situated in the posterior part of the lesser pelvis, in front of the lower three pieces of the sacrum and the coccyx. Extent. The rectum begins as a continuation of the sigmoid colon at the level of third sacral vertebra. The rectosigmoid junction is indicated by the lower end of the sigmoid mesocolon. The rectum ends by becoming continuous with the anal canal at the anorectal junction. The junction lies 2 to 3 cm in front of and a little below the tip of the coccyx. In males, the junction corresponds to the apex of the prostate. Dimensions. The rectum is 12 cm long. In the upper part it has the same diameter of 4 cm as that of the sigmoid colon, but in the lower part it is dilated to form the rectal ampulla. Course and direction. In its course, the rectum runs first downwards and backwards, then downwards, and finally downwards and forwards, Fig 33.1. The beginning and the end of the rectum lie in the median plane, but it shows two types of curvatures in its course. Two anteroposterior curves. A. The sacral flexure of the rectum follows the concavity of the sacrum and coccyx. B. The perineal flexure of the rectum is the backward bend at the anorectal junction. C3. Lateral curve. 1. Upper lateral curve of rectum is convex to right. 2. The middle lateral curve is convex to the left and most prominent. 3. The lower lateral curve is convex to right. Relations. Peritoneal covering. 1. The upper one-third of the rectum is covered with peritoneum in front and on the sides. 2. The middle one-third is covered only in front. 3. The lower one-third, which is dilated to form the ampulla, is devoid of peritoneum, and lies below the rectovesical pouch in males and below the rectouterine pouch in females. The distance between the anus and the floor of the pouch is 7.5 cm in males but only 5.5 cm in females. Relations. Anteriorly in males, 1. The upper two-thirds of the rectum are related to the rectovesical pouch with coils of intestine and sigmoid colon. 2. The lower one-third of the rectum is related to the base of the urinary bladder, the terminal parts of the ureters, the seminal vesicles, the deferent ducts and the prostate. Anteriorly in females. 1. The upper two-thirds of the rectum are related to the rectouterine pouch with coils of intestine and sigmoid colon. The pouch separates the rectum from the uterus, and from the upper part of the vagina. 2. The lower one-third of the rectum is related to the lower part of the vagina. Posterior. The relation are the same in the male and in female. They are as follow: 1. Lower three pieces of the sacrum, the coccyx, and the anacoccygeal ligament. 2. Piriformis, the coccygus, and the levator ani. 3. The median sacral, the superior rectal and lower lateral sacral vessels. 4. The sympathetic chain with the ganglion impar, the anterior primary rami of S3, S4, S5, coccygeal 1, and the pelvic splanchnic nerves, lymph nodes, lymphatics and fat. Mucosal folds. The mucous membrane of an empty rectum shows two types: O1 folds, Longitudinal and transverse. The longitudinal folds are transitory. They are present in the lower part of an empty rectum, and are obliterated by distension. The transverse or horizontal folds or Houston's valves, or plicae transversales, are permanent and most marked when the rectum is distended. A. The first small transverse fold projects from right wall. It is 12 to 14 cm above anal canal. B. The second transverse fold lies near the upper end of the rectum, and projects from the left wall situated 7.5 cm above anus. Sometimes it may encircle and partially constrict the lumen. B. The third transverse fold, the largest and most constant, lies at the upper end of the rectal ampulla, and projects from the anterior and right walls. It is some above anus. C. D. The fourth transverse fold, which is inconstant, lies 2.5 cm below the middle fold and projects from the left wall. Functional parts of rectum. The rectum has two developmental parts. The upper part, related to the peritoneum, develops from the hindgut and lies above the third transverse fold of the rectum. The lower part, devoid of peritoneum, develops from the cloaca and lies below the third transverse fold. Functionally, the sigmoid colon is the fecal reservoir and the whole of the rectum is empty in normal individuals, being sensitive to distension. Passage of feces into the rectum, therefore, causes the desire to defecate. Arterial supply. 1. Superior rectal artery. This is the chief artery of the rectum. It is the continuation of the inferior mesenteric artery at the pelvic brim, medial to the left ureter. It lies in medial limb of pelvic mesocolon and divides opposite the third sacral vertebra into right and left branches which run on each side of the rectum. Each branch breaks up at the middle of the rectum into several small branches which pierce the muscular coats and run in the anal columns up to the anal valves, where they form looped anastomoses. 2. Middle rectal vein. The tributaries of this vein drain, chiefly, the muscular walls of the rectal ampulla, and open into the internal iliac veins. 3. Lower rectal vein. It joins the left common iliac vein. Lymphatic drainage. Lymphatics from more than the upper half of the rectum pass along the superior rectal vessels to the inferior mesenteric nodes after passing through the pararectal and sigmoid nodes. 1. Lymphatics from the lower half of the rectum pass along the middle rectal vessels to the internal iliac nodes. 2. Lymphatics from the lower part of anal canal drain into superficial inguinal nodes. Nerve supply. The rectum is supplied by both sympathetic, L1, L2, and parasympathetic, S2, S3, S4, nerves through the superior rectal or inferior mesenteric and inferior hypogastric plexuses. Sympathetic nerves are vasoconstrictor, inhibitory to the rectal musculature and motor to the internal sphincter. Parasympathetic nerves are motor to the musculature of the rectum and inhibitory to the internal sphincter. Sensations of distension of the rectum pass through the parasympathetic nerves, while pain sensations are carried by both the sympathetic and parasympathetic nerves. Supports of rectum. 1. Pelvic floor formed by levator ani muscles. 1. Fascia of Valder. It attaches the lower part of the rectal ampulla to the sacrum. It is formed by condensation of the pelvic fascia behind the rectum. It encloses the superior rectal vessels and lymphatics. 2. Lateral ligaments of the rectum. They are formed by condensation of the pelvic fascia on each side of the rectum. They enclose the middle rectal vessels, and branches of the pelvic plexuses, and attach the rectum to the posterolateral walls of the lesser pelvis. 3. Rectovesical fascia of Denonvillers. It extends from the rectum behind to the seminal vesicles and prostate in front. 4. The pelvic peritoneum and the related vascular pedicles also help in keeping the rectum in position. 5. Perineal body with its muscles. Digital per rectum, PR, examination. In PR examination, the finger enters anal canal before reaching lower end of rectum. In a normal person, the following structures can be palpated by a finger passed per rectum. In males: 1. Posterior surface of prostate. 2. Seminal vesicles. 3. Vas. 4. Posterior surface of prostate. 5. Seminal vesicles. 6. Vas deferens. In females: 1. Perineal body. 2. Cervix. 3. Presenting part of the foetus during delivery. In both sexes, 1 anorectal ring. 2 coccyx and sacrum. 3 ischio-anal fossa and ischial spines. In patients, a PR examination can help in the palpation of following abnormalities. A. Within the lumen, fecal impaction and foreign bodies, bleeding piles, or hemorrhoids. B. In the rectal wall, rectal growths and strictures, and thrombosed piles. C. Outside the rectal wall, in males, the enlargements of prostate, seminal vesicles and bulbourethral glands, and stone in membranous urethra; in females, enlargements of uterus, tubes, and ovaries, and abnormalities in the pouch of Douglas; and in both sexes, the distended bladder, lower ureteric stones, and tumors of the bony pelvis. During parturition, the dilatation of cervix is commonly assessed through the rectal wall to avoid infection by repeated vaginal examinations. Toctoscopy and Sigmoidoscopy. The interior of the rectum and anal canal can be examined under direct vision with special instruments, like a proctoscope or a sigmoidoscope. Proctoscopy shows internal piles and growths in lower part of rectum. Sigmoidoscopy helps in revealing the ulcers, growths, and diverticula, and in taking a rectal biopsy. Prolapse of rectum or incomplete prolapse of the rectum through the anus may occur following violent straining. This is due to imperfect support of the rectal mucosa by the submucosa, which is made up of loose areolar tissue. Complete prolapse or procidentia is the condition in which the whole thickness of the rectal wall protrudes through the anus. The contributory factors in its causation are: a laxity of the pelvic floor, excessively deep rectovesical or rectouterine pouch, a inadequate fixation of the rectum in its presacral bed. Neurological disturbances of the rectum. In spite of the identical innervation of the rectum and bladder, the rectal involvement in nervous lesions is less severe than that of the bladder. After sacral denervation of the rectum, the peripheral nervous plexus controls the automatic evacuation of the rectum. This reflex activity is more massive and complete when sacral of innervation is intact, e.g. complete cord lesion above the sacral region. However, due to weak musculature of the rectum and sparing of the tone of the external sphincter by transverse lesions of the cord, rectal disturbances tend to cause constipation, although complete lesions may cause reflex defecation. Carcinoma of rectum. It is quite common, and is generally situated at the rectosigmoid junction, constricting type, or in the ampulla, proliferating type. It causes bleeding per rectum from an indurated raised ulcer. The condition is surgically treated by an abdominoperineal excision in which the anus, anal canal, and rectum with their facial sheaths, and a varying amount of distal colon along with its mesocolon containing the lymph nodes are removed en bloc, and a permanent colostomy in the left iliac fossa is done with the proximal cut end of the colon. Rectal continence. Rectal continence depends solely on the anorectal ring. Damage to the ring results in rectal incontinence. The surgeon has to carefully protect the anorectal ring in operating on the region. Dissection. Identify the relations of the anal canal in both male and female. Examine the lining of the anal canal. Strip the mucous membrane and skin from a sector of the anal canal. Identify the thickened part of the circular muscle layer forming the internal sphincter of the anus. Locate the external anal sphincter with its parts, partly overlapping the internal sphincter. The anal canal is the terminal part of the large intestine. Situation. Anal canal is situated below the level of the pelvic diaphragm. It lies in the anal triangle of perineum in between the right and left ischio-anal fossae, which allows its expansion during passage of the faces. The saculations and tenyi are absent here also. Length, extent, and direction. The anal canal is 3.8 centimeters long. It extends from the anorectal junction to the anus. It is directed downwards and backwards. The anal canal is surrounded by inner involuntary and outer voluntary sphincters which keep the lumen closed in the form of an antero-posterior slit. The anorectal junction is marked by the forward convexity of the perineal flexure of the rectum and lies 2-3 cm in front of and slightly below the tip of the coccyx. Here the ampulla of the rectum suddenly narrows and pierces the pelvic diaphragm. In males it corresponds to the level of the apex of the prostate. The arms is the surface opening of the anal canal, situated about 4 cm below and in front of the tip of the coccyx in the cleft between the two buttocks. The surrounding skin is pigmented and thrown into radiating folds, and contains a ring of large apocrine glands. Relations of the anal canal: anteriorly, 1 in both sexes, 2 in males, membranous urethra and bulb of penis. In female, lower end of the vagina. Posteriorly, 1 anacoccygeal ligament. 2 tip of the coccyx. Laterally, ischio-anal fossa. All round, anal canal is surrounded by the sphincter muscles, the tone of which keeps the canal closed. Interior of the anal canal: the interior of the anal canal shows many important features and can be divided into 3 parts, the upper part about 15 mm long, the middle part about 15 mm long, and the lower part about 8 mm long. Each part is lined by a characteristic epithelium and reacts differently to various diseases of this region. Upper mucous port. 1. This part is about 15 mm long. It is lined by mucous membrane, and is of endodermal origin. 2. The mucous membrane shows, A6, 10 vertical folds. These folds are called the clumps of Morgagni. B. The lower ends of the anal columns are united to each other by short transverse folds of mucous membrane. These folds are called the arm valves. A. Above each valve there is a depression in the mucosa which is called the anal sinus. B. The anal valves together form a transverse line that runs all round the anal canal. This is the pectinate line. It is situated opposite the middle of internal anal sphincter, the junction of ectodermal and endodermal parts. Occasionally the anal valves show epithelial projections called rival papillae. These papillae are remnants of the embryonic anal membrane. C. The anal sinus contains anal glands. The secretion of these glands produce peculiar smell which is important in lower animals to attract. Middle part or transitional zone or pectin. 1. The next 15 mm or so of the anal canal is also lined by mucous membrane, but anal columns are not present here. The mucosa has a bluish appearance because of a dense venous plexus that lies between it and the muscle coat. The mucosa is less mobile than in the upper part of the anal canal. This region is referred to as the pectin or transitional zone. The lower limit of the pectin often has a whitish appearance, because of which it is referred to as the white line of Hilton. Hilton's line is situated at the level of the interval between the subcutaneous part of external anal sphincter and the lower border of internal anal sphincter. 2. It marks the lower limit of pectin or stratified squamous epithelium which is thin, pale, and glossy and is devoid of sweat glands. Lower cutaneous port. It is about 8 mm long and is lined by true skin containing sebaceous glands. The epithelium of the lowest part resembles that of pigmented skin in which sebaceous glands, sweat glands, and hair are present. Musculature of the anal canal: anal sphincters. The internal anal sphincter is involuntary in nature. It is formed by the thickened circular muscle coat of this part of the gut. It surrounds the upper 3/4, i.e. 30 mm of the anal canal, extending from the upper end of the canal to the white line of Hilton. The external anal sphincter is under voluntary control. It is made up of a striated muscle and is supplied by the inferior rectal nerve and the perineal branch of the fourth sacral nerve. It surrounds the whole length of the anal canal and has 3 parts: subcutaneous, superficial and deep. Contrary to earlier view, the external anal sphincter forms a single functional and anatomic entity. Uppermost fibers blend with fibers of puba rectalis. Anteriorly some fibers decussate with superficial transverse perineum muscle and posterior fibers get attached to anacoccygeal raphe. Middle fibers surround lower part of internal anal sphincter. These are attached to perineal body anteriorly and to coccyx via anacoccygeal ligament posteriorly. Some fibers of each side decussate to form a commissure in the midline. Lower fibers lie below the level of internal anal sphincter and are separated from anal epithelium by submucosa. In males, transverse perineum and bulbospongiosis end in central point of perineum, so that there is a surgical plane of cleavage between urogenital triangle and anal canal. In females, the puba rectalis is separate from external anal sphincter. Its anterior portion is thinner and shorter. In addition, in females, transverse perineum and bulbospongiosis fuse with external anal sphincter in lower part of perineum. Conj ointment longitudinal coat. It is formed by fusion of the puba rectalis with the longitudinal muscle coat of the rectum at the anorectal junction. It lies between the external and internal sphincters. When traced downwards it becomes fibroelastic, and at the level of the white line it breaks up into a number of fibroelastic septa which spread out fan-wise, pierce the subcutaneous part of the external sphincter, and are attached to the skin around the anus called as corrugator cutis ant. The most lateral of these septa forms the perianal fascia. The most medial septum forms the anal intermuscular septum, which is attached to the white line. In addition, some strands pass obliquely through the internal sphincter and end in the submucosa below the anal valves. Anorectal ring. This is a muscular ring present at the anorectal junction. It is formed by the fusion of the puba rectalis, uppermost fibers of external sphincter and the internal sphincter. It is easily felt by a finger in the anal canal. Surgical division of this ring results in rectal incontinence. The ring is less marked anteriorly where the fibers of the puba rectalis are absent. Surgical spaces related to the anal canal. 1. The ischio-anal space or fossa lies on each side of the anal canal. 2. The perianal space surrounds the anal canal below the white line. It contains the lower fibers of external sphincter, the external rectal venous plexus, and the terminal branches of the inferior rectal vessels and nerves. Pus in this space tends to spread to the anal canal at the white line or to the surface of the perineal skin rather than to the ischio-anal space. 3. The submucous space of the canal lies above the white line between the mucous membrane and the internal sphincter. It contains the internal rectal venous plexus and lymphatics. Arterial supply. 1. The part of the anal canal above the pectinate line is supplied by the superior rectal artery. 2. The part below the pectinate line is supplied by the inferior rectal arteries. Venous drainage. The internal rectal venous plexus or hemorrhoidal plexus lies in the submucosa of the anal canal. It drains mainly into the superior rectal vein, but communicates freely with the external plexus and thus with the middle and inferior rectal veins. The internal plexus is, therefore, an important site of communication between the portal and systemic veins. The internal plexus is in the form of a series of dilated pouches connected by transverse branches around the anal canal. Veins present in the 3 anal columns situated at 3, 7, and 11 o'clock positions as seen in the lithotomy position are large and constitute potential sites for the formation of primary internal piles. 2. The external rectal venous plexus lies outside the muscular coat of the rectum and anal canal, and communicates freely with the internal plexus. The lower part of the external plexus is drained by the inferior rectal vein into internal pudendal vein, the middle part by middle rectal vein into internal iliac vein, and the upper part by superior rectal vein which continues as the inferior mesenteric vein. 3. The iliac veins are arranged radially around the anal margin. They communicate with the internal rectal plexus and with the inferior rectal veins. Excessive straining during the defecation may rupture one of these veins, forming a subcutaneous perianal hematoma known as external piles. Lymphotic drainage. Lymph vessels from the part above the pectinate line, drain with those of the rectum into the internal iliac nodes. Vessels from the part below the pectinate line drain into the medial group of the superficial inguinal nodes. Nerve supply. 1. Above the pectinate line, the anal canal is supplied by autonomic nerves, both sympathetic, inferior hypogastric plexus, L1, L2, and parasympathetic, pelvic splanchnic, S2, S3, S4. Pain sensations are carried by both of them. 2. Below the pectinate line, it is supplied by somatic, inferior rectal, S2, S3, S4, nerves. 3. Sphincters. The internal sphincter is caused to contract by sympathetic nerves and is relaxed by parasympathetic nerves. The external sphincter is supplied by the inferior rectal nerve and by the perineal branch of the 4th sacral nerve. Histology, rectum. The mucous membrane of rectum has many large folds. The epithelium and crypts contain abundant goblet cells. Submucosa contains plexus of nerves and capillaries. Muscularis externa is of uniform thickness. Serosa is seen in upper part and adventitia in lower part. Anal canal, the epithelium lining of upper 15 mm is simple or stratified columnar, while that of middle 15 mm is stratified squamous without any sweat gland or sebaceous gland or hair follicle. The epithelium of lowest 8 mm resembles that of true skin with sweat and sebaceous glands and hairy follicles. The thick inner circular layer covers the upper 3/4 of anal canal to form the internal anal sphincter. The outer longitudinal layer is a thin layer. Outside these smooth muscle layers is the striated external anal sphincter. Development rectum distal part of hindgut known as cloaca is devied by anorectal canal posteriorly and vesico-urethral canal anteriorly. Primitive anorectal canal forms the lower part of rectum and proximal part of anal canal. Its distal part of anal canal is formed by the proctodeum. Upper part of rectum, i.e. part above the third transverse fold of rectum, develops from endoderm of hindgut. This part is related to peritoneum. Lower part, below the third transverse fold, is formed from the dorsal part of the cloaca. It is devoid of peritoneum. Anal canal, upper 15 mm develops from the primitive anorectal canal. Lower part below the pectinate line, lower 15 plus 8 mm, is formed from ectodermal invagination, i.e. proctodeum, Greek on the way to. Non-continuity of the two parts results in imperforate anus. This table shows comparison of upper and lower parts of anal canal. Piles or hemorrhoids, internal piles or true piles are saccular dilatations of the internal rectal venous plexus. They occur above the pectinate line and are, therefore, painless. They bleed profusely during straining at stool. The primary piles occur in 3, Z and 11 o'clock positions of the anal wall when viewed in the lithotomy position. They are formed by enlargement of the three main radicles of the superior rectal vein which lie in the anal columns which occupy the left lateral, right posterior, and right anterior positions. Varicosities in other positions of the lumen are called secondary piles. The various factors responsible for causing internal piles are, A. Poor support to veins from the surrounding loose connective tissue, so that the veins are less capable of resisting increased blood pressure, B. Absence of valves in the superior rectal and parietal veins. C. Compression of the veins at the sites where they pierce the muscular coat of the rectum. D. Direct transmission of the increased portal pressure at the portosystemic communications. For these reasons the development of piles is favored by constipation, prolonged standing, excessive straining at stool, and portal hypertension. External piles or false piles occur below the pectinate line and are, therefore, very painful. They do not bleed on straining at stool. Fissure in anal fissure is caused by the rupture of one of the anal valves, usually by the passage of dry hard stool in a constipated person. Each valve is lined with mucous membrane above, and with skin below. Because of the involvement of skin the condition is extremely painful and one's associated with marked spasm of the anal sphincters. Fistula in ano, a fistula is an abnormal epithelialized tract connecting two cavities, or one cavity with the exterior. Fistula in ano is caused by spontaneous rupture of an abscess around the anus or may follow surgical drainage of the abscess. Most of these abscesses are formed by the small vestigial glands opening into the anal sinuses. Such an anorectal abscess tends to track in various directions and may open medially into the anal sinus, laterally into the ischio-anal fossa, inferiorly at the surface, and superiorly into the rectum. A fistula can also be caused by an ischio-anal or a pelvirectal abscess. The fistula is said to be complete when it opens both internally into the lumen of the gut and externally at the surface. More severe malformations of the anorectal region include the following. A. Anal stenosis. B. Anal agenesis with or without a fistula. Anorectal agenesis with or without a fistula. Most of the anorectal malformations are caused by abnormal partitioning of the cloaca by the urorectal septum. Middle lateral curvature of rectum is most prominent. It is convex to the left side. Chief artery of rectum is superior rectal and chief vein is superior rectal vein. Perineal body and levator ani from the main supports of rectum. Most of the anal canal is surrounded by internal and external anal sphincters. Only middle fibers of external sphincter have a bony attachment. Proximal 15 mm of anal canal develops from anorectal canal, endoderm, and distal 23 mm develops from the proctodeum, ectoderm. Primary piles appear at 3, 7, 11 OC1 OC positions.